This is an example of how to present a manuscript describing a randomized trial. My main goal is to provide you with an illustration of the structure of the presentation and the desired level of detail. You don't have to precisely follow this structure. Also, I went low-tech and a little lazy, probably erred on the side of saying too little. Students also often cut and paste information from the article, such as data tables, into their presentations, and that's good. More graphics would have been helpful, for example, a drawing of a tonsil, so long as there aren't so many bells and whistles as to be distracting. This is a study of children with sleep apnea, which is an involuntary pause in breathing. Not breathing is a bad thing. One of the resulting problems is an inadequate amount of oxygen to the brain, which in turn can cause cognitive defects, among other bad things. Sleep apnea is caused by the obstruction of the upper airway. Large tonsils can cause such an obstruction. Doctors hope that removing the child's tonsils will remove the obstruction, thus eliminate the cause of the sleep apnea. Accordingly, the primary study question is whether or not children with sleep apnea should have their tonsils removed. The reason that the question is important is that while doctors often perform this procedure, they don't have definitive evidence that it works. Obtaining this evidence is important. Otherwise, children will have been needlessly exposed to the risk of the surgery, and their parents will have had to pay its cost. This is a multi-site randomized trial of children with obstructive sleep apnea syndrome. The study groups are surgery and watchful waiting. The follow-up period is 7 months. The outcome variables can be classified as sleep quality, cognitive, behavioral, and health outcomes. The primary outcome is the NESPI, a measure of attention and executive function, essentially quality of thinking. Data collectors were blinded to study group. The primary outcome variable was continuous, thus the impact of surgery was assessed using analysis of covariance. Subgroup effects, that is, whether the impact of surgery was consistent across subgroups, were quantified using interaction terms within the ANCOVA model. The power calculation was based on specifying a generic effect size of 0.32. This effect size didn't appear to be well justified. The consort diagram suggested relatively little attrition. The groups were similar at baseline. The NESPI scores were near the population mean. In other words, it doesn't look as if sleep apnea has caused long-term harm to the children being studied. This would make me wonder whether the study has a ceiling effect. In other words, as far as the primary outcome variable is concerned, children might have little room to improve. The NESPI score improved by 7.1 units in the surgery group, in comparison with 5.1 units in the controls. The magnitude of this difference is 2.0 units. This difference isn't statistically significant, as illustrated by the p-value of 0.16. The manuscript didn't provide a confidence interval around the effect size, nor did it comment on its possible clinical significance. Many of the secondary outcomes were statistically significant and all favored surgery. What tended to significantly improve were measures of sleep quality, quality of life, and behavior. What didn't improve was intellectual functioning. Few adverse events were seen in either group. For the primary analysis, the impact of surgery was similar across subgroups. Some differences of the differential impacts of surgery by race and apnea severity were seen for some of the secondary outcomes. This seemed like moderately strong evidence of subgroup effects at best. In summary, although all of the outcomes favored surgery, the statistically significant ones tended to pertain to sleep quality, quality of life, and behavior. Neither the primary outcome of attention and executive function nor the secondary outcome of intellectual functioning showed statistically significant changes. Some of the limitations of the study design include the exclusion of severe causes of sleep apnea, a short follow-up period which might not have provided enough time to observe an impact on intellectual functioning, and the possibility that the primary outcome variable might have had a ceiling effect. Some limitations of the statistical analyses include the relative paucity of measures of precision and the lack of discussion of clinical significance. At the end of the day, the authors said relatively little about the important element of how this study should be interpreted. Namely, they didn't say whether this is a positive or a negative study. We observed statistically significant improvement associated with surgery for various intermediate variables, the clinical significance of this being uncertain. We didn't observe a statistically significant difference between the groups for the primary outcome, although the direction favored surgery. If this study were definitively negative, I'd recommend not performing the surgery. The authors didn't decide to say this. The study provided strong evidence in favor of the surgery, then one would continue to recommend that surgery, but obviously that's not what occurred here. The study provided weak evidence in favor of the surgery. It really isn't clear what to recommend. That's probably how the authors interpreted the results, and perhaps why they didn't make any recommendations at all.